I'm going to present some data actually on behalf of Eric Systemski and colleagues. Eric is here in the room, so if you have any questions, ask him. These are my disclosures, and I want to present two manuscripts that this consortium of investigators put together with Eric and Bobby Ye's guidance, the first of which was published online February 12th of this year, and the title is Association of Survival with Femoropopliteal Artery Revascularization with Drug-Coated Devices. These data were presented in the manuscript in JAMA Cardiology, and what you will see is collated data from Medicare databases looking at a series of patients who received both drug-eluting stents and drug-coated balloons using the ICD-10 paradigm. So these are inpatients in a region of the United States. And what you'll notice is that the baseline characteristics of age is consistent with a Medicare population, 73 years of age, roughly, predominantly both men and predominantly women, actually, Caucasian, and with a high prevalence of critical limb ischemia and a burden of diabetes, which is concomitant with that presentation. In order to regularize the types of hospitals that were represented, bed size was considered, as well as metropolitan or non-metropolitan teaching or non-teaching hospital status. And you can see that there's relatively equal distribution. And the take-home slide from this manuscript really is that there was no significant difference, and slightly, in fact, a crude risk reduction with the use of drug-eluting technologies at a median follow-up just under 2 years. And so if you look at Medicare beneficiaries, about half of whom are CLI patients, there was no difference in terms of mortality at this relatively long-term follow-up. When looking at balloon angioplasty, again, there was no difference in the plain old balloon angioplasty versus DCB arms. And again, similarly, with drug-eluting stents, predominantly the Zilver PTX device compared to bare metal nitinol self-expanding stents, there is no difference. I think what is striking is that in this cohort of patients, there is a mortality approaching 1/3 at such a short near-term follow-up, and this is reflective of the patient population that we're treating here in contemporary practice. And again, if you look at the critical limb patient population, the mortality hazard at less than 600 days approaches 40%. So this is an extremely high-risk patient population, and again, is reflective of our clinical practice here in the United States. Again, without CLI, this is about 1/3 mortality. So the conclusion from the first manuscript was that there was no difference in survival between drug-coated and uncoated devices, and this was when reviewed via device type or CLI status. And the follow-up data was admittedly short at 600 days, largely because the ICD-10 paradigm had only recently been introduced in the United States, and it was with the granularity of ICD-10 that we were able to discriminate between drug-coated balloons and drug-eluting stents. So as a follow-up to this, Eric and his team, which included several of us, looked at ICD-9 paradigms, which went back many more years and included the initiation of drug-eluting technologies here in the United States. And in this analysis, over 51,000 Medicare beneficiaries were reviewed who had received drug-eluting stents, again, Zilver PTX or bare metal nitinol self-expanding stents between the years of 2012 and 15, with the FDA approval of Zilver PTX having just preceded this. All-cause mortality was reviewed with a median follow-up of 2 years and a longest follow-up of 4.1 years. And again, using the ICD-9 paradigm, we were able to identify the use of DES in a non-coronary vessel. Here's the summary data, again, with a follow-up out to 1,440 days. You can see the jaw-dropping mortality of approximately 50% in both cohorts of patients, with similar patient characteristics as I showed earlier, but again, no difference between the drug-eluting versus non-drug-eluting technologies. And there was no survival hazard, and the confidence intervals are relatively narrow because of the large data set. When stratified by critical limb ischemia status, you can see, obviously, as one would expect, that the non-CLI patients have a much lower hazard of mortality. However, there's no difference between the two groups. And again, this subsumes some 50,000 patients in the United States. And so the conclusions from this manuscript and really the pair of manuscripts is that among Medicare beneficiaries, there's no difference in relatively midterm or long-term outcomes in terms of all-cause mortality in those patients treated with drug-coated versus uncoated devices. And this relationship persisted between device types, both DCB and DES, and those with and without critical limb ischemia. I certainly would encourage you to come to Eric's talk later this afternoon, where he'll be, as I understand, unveiling some new data and some updates to these data. And certainly I understand at next week's FDA panel, he'll be dropping even more data. So there's more to come. Thanks very much.